Well, hello there, everyone, and welcome. On behalf of Abbott, we want to thank you for taking time to attend today's program. This is VAD Coordinator Patient Management Review, presented by our two presenters today, Daphne Fovell and Sarah Shettle. I'll give you more information about them in just a moment. A few disclaimers to share with everyone that is joining us. The content in this presentation does represent the beliefs of our speakers and does not necessarily reflect the views of Abbott. Information presented is consistent with applicable FDA guidelines. This content reflects the speaker's experience, and the applicability of this experience should be considered in the context of your individual centers and patients' needs. The speakers are presenting at the request and on behalf of Abbott. An honoraria is being provided. This meeting not intended for CEU credits, and again, support for the program is provided by Abbott. With that, let me introduce the two folks that you see on screen that will be joining and sharing with all of us here today. Daphne Fovell is the lead LVAD coordinator at Montefiore Medical Center in the Bronx, New York. She collaborates with multidisciplinary team members to really manage complex patient care, develops and implements strategies for the program's growth, and contributes to heart failure research studies and protocol development. We're glad to have Daphne on board. She is joined by Sarah Shettle, a physician assistant and ventricular assist device coordinator in the Department of Cardiovascular Surgery at Mayo Clinic in Rochester, Minnesota. She also serves as an associate professor of surgery at the Mayo Clinic College of Medicine and Science. Sarah has 15 years of experience advancing the field of mechanical circulatory support. With that, again, we remind you to get those questions and comments in as we go through the presentation. Sarah, I've brought up the agenda. We'll have you briefly go through that, and then we'll get into the content. We've got a lot to cover today.
Perfect. Thank you so much. And a big thank you to everyone for joining. We're very excited, both Daphne and I, to spend some time with you today to go over all things LVAD. We'll be spending a bit of time going through a heart failure overview and some LVAD outcomes. We'll then transition into evaluation of patients and management of outcomes. We'll share a few educational resources and some strategies to improve access to care. And we'll conclude with some challenging clinical situations that I'm sure most of us have probably experienced in our care of LVAD patients. And finally, we want to open up to you for some questions that hopefully we can answer and together improve the field of mechanical circulatory support. So with that, I think that we all know that there are a lot of patients that have advanced heart failure. But I think what is interesting to note is that of the LVAD population, that's implanted in 1 year, for example, maybe 3,500 in 2024, there's perhaps 4,500 transplants that are also done in that same year. But there's a significant number of patients that have unmet needs. In fact, 21 of 22 patients that do not receive a heart transplant actually can die while waiting for support. So I think this is something that we as clinicians can do to advance mechanical circulatory support, is to ensure that patients who could benefit from care have those options available to them. And Abbott has certainly partnered in that space with mechanical circulatory support and has several clinical trials that show how LVAD has really improved the field for patients with advanced circulatory failure. In the upper left corner, you can see the MOMENTUM trial that many of us are familiar with, showing that there is about a 60% survival at 5 years, which is certainly a very impressive number. Then if you look below that, Abbott recently published the ARIES HeartMate 3 trial, which showed that reduction of adverse events like GI bleeding and less hospitalizations can be associated with reduction or essentially exclusion of aspirin altogether in HeartMate 3 patients. Then if you look at 2024, the INTERMACS report does show that the same outcome, 60% survival at 5 years, reflects the similar data that you would see in the MOMENTUM trial. And we'll spend a little time today talking about the ASPIRE study, where Abbott has partnered with VAD coordinators to show how utilization of dressing changes and frequencies can improve adverse events from an infection perspective. So with that, I'll turn it over to Daphne to spend a little bit of time talking about patient evaluation and volumes.
Thanks so much for joining us. Today, we're going to start with managing referrals, because in order to get an LVAD implanted, we have to kind of find the patients first. So one of the things that we can do as clinicians and as team members is utilize our EHR to capture patients that haven't made contact with the heart failure team as of yet. At our facility, we do use Epic, but depending on what you're using, you may be able to collaborate with your IT or EHR teams to generate automatic reports for patients who have EFs lower than a preset threshold. You can also get automatic reports for patients who are coming in through your emergency departments with a specific diagnosis. So if you want to search for people who are coming in for decompensated heart failure or volume overload, things of that nature. You can also develop pathways where there are direct contact numbers for outside individuals to reach out to your heart failure team without having to go through the muck of operators or looking for one specific person, but having that direct line of contact can help people get in contact with your team as soon as possible. Another strategy that could be implemented is establishing an e-consult strategy where collaboration can happen prior to the patient needing advanced therapy. So you can get these patients consulted, make your recommendations, and they can establish care, hopefully on an outpatient basis, but even on an inpatient basis before the advanced therapies are needed. For evaluating your patients, some things that we can really reconsider: caregiver requirements. Is this really necessary? Because we see the Intermax data showing that patients who are at higher psychosocial risk actually still do well. So is it still a requisite to have somebody need a caregiver if they are younger and they can show that they can independently manage their items, their LVAD equipment and dressing changes and getting to appointments? Testing. These things can kind of hold up getting our patients to LVAD therapy. So are there some testing that can be deferred? Do we need to really wait for a colonoscopy, especially for someone who is clinically unstable? Are there other testing methodologies we can use, like Cologuard or CT scans, in order to get these things evaluated if we deem they are absolutely necessary? And also getting patients in line with the proper insurance coverage that is needed. There are people who may be insured by their employers at the time of evaluation, but getting back to the type of work that they are into may not be a realistic option post LVAD. So are we gathering the necessary information needed so that when this insurance does terminate or these people do no longer qualify for a plan, now is not the time that we're trying to gather, documents at home and we're trying to find out if they can direct someone at home. Getting this information before implant and having a plan prior could help facilitate getting a patient to LVAD therapy and sustaining them through therapy without lapses in care. For managing our overall patient volume, we went from getting referrals to getting patients evaluated, and now we have more patients than we've had before. We really have to consider the structure of our teams and how our teams are staffed. I do think that teams are best served by having a mix of different type of personnel. So whether they are advanced practice providers, nurses, or non-clinical staff, and making sure that you are using your staff appropriately. We don't want to have our advanced practice providers doing a bunch of non-billable, non-clinical work when this can be assigned to someone else and the focus on clinical care can be done by the advanced practice staff or the nursing staff. Ensuring and strongly encouraging that other hospital departments are trained on how to take care of the LVAD patient. And once again, this goes back to appropriately using your staff members. You once again do not want to have your clinicians sitting in on procedures where they can be covered by somebody else, where they're not able to bill, they're not able to take care of patients the way they need to because they're kind of stuck in other ancillary areas doing work that is not necessarily clinically geared. Another thing to consider is offloading certain tasks to different departments. As your volume grows, is it really feasible for your team to continue to monitor INRs? Is this something you can give to a Coumadin clinic to take care of? Is this something where you may have a clinical pharmacist who can take care of this? Equipment is another thing. If you do not have a dedicated equipment person, is this something you really want your advanced practice providers and your nurses taking care of? There are DME providers who can help manage the equipment, and it also assists with regulatory items, because if you have a clinic that's full of equipment, that's more stuff that you can possibly have a finding for, because you need to make sure your equipment is stocked, it's not expired, and it's used appropriately and it's assigned appropriately. So offloading that task to a DME, if you do not have someone designated specifically for equipment, is another opportunity where you can have better patient management by getting rid of tasks that can be done by somebody else. OR coverage is another thing. Do you want your clinicians sitting in the OR for extended periods of time, not doing other things except for that case? Are there other team members cardiac anesthesia, perfusion, other personnel that can take over those duties so that these individuals are not relegated to sitting in the OR for extended period of times. I'm going to turn it over to Sarah to go over patient education resources.
Thank you. And I would certainly say that resources are something that I, as a VAD coordinator, depend on, whether it's for patients or even just for other providers or when I go to do outreach. So I think that knowing what's available and having access to that is incredibly helpful. Here on the screen, you can see several of the tools and resources that Abbott makes that are available for you as a coordinator to share with your patients for educational purposes. And I'd like to highlight in the upper right corner on that patient ID tag. If you don't have these, something like this is really quite helpful that offers a pictorial representation of the device as well as contact information that the patient can self-elect to fill out. So if you have a patient who's traveling or a patient that wants to have a luggage tag for their equipment, this is a very helpful resource. So don't forget to use the resources that are available. If there's things either here or on this next slide that you see that you haven't yet been able to utilize or that you'd like to learn more about, feel free to reach out to your Abbott rep and they'd be happy to share some of these resources with you. As far as resources that I use with my patients, and even in deciding when to refer or how to refer, numbers 3 and 4 in the lower left corner are great pictorial at-a-glance slides that really help identify where some of this need is in referral for LVAD and kind of provides an overview of what the therapy all entails. So I think that having things like this at your disposal, whether it's in clinic when you're seeing patients who are candidates for LVAD, or whether you're speaking with other clinicians perhaps who want to know when to refer, or chatting with your patients and other providers, I think these are great tools to have available for you. And finally, I would like to highlight, just because it's something that we utilize a fair bit at our program, is the Patient Ambassador Program. So I'm sure everybody that's on this call has a cell phone. So if you get your phone out, you can scan this QR code here and have a link to the Patient Ambassador Program. This is extraordinarily helpful if you're trying to connect a patient perhaps who's contemplating LVAD therapy and isn't quite sure what it's actually like to live with an LVAD. You can reach out to Abbott and say, hey, I have a patient who's a farmer in the Midwest who would like to talk to somebody else who's a farmer. And they can connect your patient with that person. Or they're a mom in the New England area or whatever it may be. Those options are available. And I can tell you that patients find it to be so helpful to have someone that they can talk to who's kind of been there, done that and lived through LVAD therapy. So this is a very, very helpful resource. Don't forget to take advantage of this for your patients. So with that, I'll turn it back over to Daphne here to chat about barriers to care and how we can improve upon that.
So removing barriers to care, let's think about some of the factors that impact health. For example, we have here that, health outcomes, health factors, policies, and programs. Social and economic factors contributes to 40% of the risk factors that impact health. These are education, employment, income, family, social support, and community safety. Just a little background on our patient population. I'm at Montefiore Medical Center, and we are in the Bronx, New York, and we are one of the poorest U.S. congressional districts. The poverty rate for the U.S. was 11.1% in 2023. The Bronx was 26.9%. So we are very much used to working with a high-risk population. And as you can see, for education and poverty, a lot of our patients, unfortunately, are not obtaining higher levels of education. Some of them have no degree, 28% are at high school graduate level, 25% at associates, and 21% at bachelor's degree. Getting into some of our federal resources, as everyone knows, there's a lot happening in our political climate today. And with any administration change, there are going to be changes to these programs. So I'm going to talk about them as they are right now. These things are subject to change. And we're going to also talk about some local resources or things that you should consider when thinking about patients and removing barriers to care. SNAP is something that has probably been on the forefront of a lot of people's mind because it keeps coming up more recently, and that, funding for SNAP may not be available November 1st. SNAP is a supplemental food program. It is federally and state funded, and it provides benefits to low-income individuals or families so that they can obtain food. So as of right now, because of the government shutdown, there is no federal funding for SNAP, and that puts a lot of individuals at risk for receiving their benefits since it is federally funded. Um, this is the opportunity for us to really look into other programs that can provide meal services, something like Meals on Wheels or other church charities or things in your community, food banks that are local to your patients. Some insurance companies actually do cover meal services, which I'll demonstrate a little bit later how that comes up. But SNAP is a great resource when it is available. The requirements for SNAP are changing in the next year. They are looking to have some type of work requirement for certain individuals. So you will need to evaluate that on a patient by patient basis. Another program is the Lifeline program. And this is huge for individuals, especially as things are changing to more electronic type of platforms. This is a service that is federally funded, and essentially it can provide individuals with internet service at home or cellular service with data. And this is important, especially, like I said, as things are becoming more electronic, patients have access to their charts electronically, their appointment reminders are coming electronically. You being able to get in touch with them and them being able to get in touch with you is also very important. So this service typically is completely covered. There's no cost to the patient. And for a cellular phone, they can get a device and monthly service covered as long as they meet the income requirement. One of the more popular pathways to get this is called Assurance Wireless. Their site is live and active. I don't know of any impending changes to this program. We have used it in the past in our program, and it has worked well. So if a patient does have a phone that they want to carry over, they can carry over that phone, but their phone number will have to change. That's one caveat. Some people are a little committed to their phone numbers and not ready to let it go, but this is a pathway to get your patient cellular service. LIHEAP, or Low Income Home Energy Assistance Program, is another program that unfortunately is probably going to be hitting the chopping block soon. The federal staff for this program was terminated this year, but the funds that were allocated for this program are still available on the statewide basis. So it is a federally funded program with funds dispersed to the states. The states still have control over the funds for 2025, but the program is slated to be discontinued in 2026. This program helped with energy costs. In New York, energy costs are through the roof, and patients complaining about it is something we do hear after they get implanted with their LVAD and having to have certain pieces of equipment plugged in, and they complain about how much higher their energy bills are. So for 2025, you can still reach out to your local LIHEAP, Low Income Home Energy Assistance Program rep, to see if there are funds available. But for 2026, this program is slated to be terminated. Next is housing. This is a big one. Section 8 is a federally and state funded program that helps provide funds for people to get stable housing. This is super challenging as you hear about housing crisis and things like that. Homelessness is something that does not do well for LVAD patients. So this program is one that a lot of patients we would love to give access to. In the New York area where we are, there is a waiting list, but there are other programs that we can utilize. But this is a program that helps provide housing subsidies for individuals, and it limits the rent contribution to 30% of that individual's income. So there's not a hard fixed dollar amount that someone's going to have to pay, like $1,000 a month or $300 a month. It's going to be solely based on their income. There are cuts expected to this program in 2026. So it's not going to be completely annihilated, but it is something where funding will become less and the rules may become a bit more stringent as we move forward. But this is a housing program that is federally funded, and your local municipalities can help you navigate getting those funds for those individuals. This is my personal favorite federal program, and this is great for your patients who are Medicaid recipients. It is the Consumer Directed Personal Assistance Program, also known as CDPAP. This allows individuals to get a friend or family member to be their caregiver. So if your program is still requiring caregivers, you can imagine it's challenging for individuals who have to work. This allows family members or friends to be the caregiver and get paid for the care that they are providing their family or friend. So once this person has been identified, forms have to be completed, and they can start as being their caregiver and get reimbursed. Depending on how long that takes to happen is state contingent, because it is based on Medicaid, which is a state, it's a federal program, but it is regulated by the states. So it may take a month or two before someone can actually get completely rolling, but it's a great asset to have. CDPAP is the generic name for it, but if you search by state, you can look and just kind of Google, like, what is it called in my state here? This is what it's called in North Carolina, Home Care Independence. In Pennsylvania, it's called something else. And that is a great program to utilize to meet that caregiver requirement. I highly recommend it for anyone you have that is a Medicaid recipient and is in need of home care or caregiver services. Social Security disability income is another program that a lot of people, especially people who are working and have careers, become a little bit, they bank on it a lot. They imagine, I've been working, I've been contributing, and I become disabled, that they would be able to get Social Security disability benefits. And they can. It is not an immediate item, though, and that can be a barrier for a lot of people. So generally, most people would have to have been working 5 out of the last 10 years prior to their disability, and they usually have to be disabled for consecutively for a year or more. There are certain conditions where they can get disability immediately, such as individuals with ALS or dialysis. And they also do have the potential to earn supplemental income. That income cannot exceed $1,550 a month, but they can work a little bit and make no more than that, and also receive their Social Security disability. So while they're waiting for Social Security disability, this is the recommendations that I got from Gemini AI: to get other income, to cut their expenses, sell assets, refinance debt. Get other income. The recommendation is to ask your friends or family, or use income from your spouse, and to apply for assistance. So a lot of these prior programs that I am referencing are what is supposed to be holding people over until they can get their Social Security disability income. Sometimes there is some stigma from individuals where they feel like, I don't want to be on welfare, or, they have a little bit of shame surrounding applying for certain programs. But that's what these programs are made for, to hold you over until you can get your Social Security disability income. So that's something to keep in mind, where you have patients who are speaking on like, oh, I'm going to get this, or I'm entitled to this. Letting them know that this is not something that's necessarily immediate is helpful. The next thing I want to talk about is Distress Community Index. And this is another way to kind of look at your community and see what kind of population you're serving, because this gets a little bit more granular than just the census data where, oh, I'm in Bronx, New York, poorest congressional district. That's not the whole entire Bronx, because there are areas of Bronx where the income is a bit higher. This can actually stratify by zip code the type of communities that you are serving. And the Distress Community Index looks at these 5 quintiles, whether someone is prosperous, comfortable, mid-tier, at risk, or distress. And it takes into account these 7 variables: high school diploma, housing vacancy rate, adults not working, and things like that. So to get into a more granular view of what's going on in the communities surrounding your hospital or the patients you're serving, the Distress Community Index is a great way to look at that. And just to give a little highlight, this area considered the Rust Belt, and the Midwest, the South, the South Midwest and the Southern states are some of the most distressed communities in the whole entire United States. So we have a large swath of the country that is considered distressed. And that's something to consider when we're looking at resources and things like that, that there are communities or states that are highly distressed in their population. Just want to give a couple examples of things that we have utilized at Montefiore to assist some of our patients. Remember, I said Section 8 is a great program for housing, but there can be a wait list. It can take some time. And we've utilized other resources we have available. This is a patient who had housing struggles, and we finally have a program that is responding to us, letting us know. And this was as recent as October 15th of this year, letting us know, hey, we are able to assist this patient with housing. And this is outside of Section 8. This is another program within the state that helps individuals who are considered disabled. So there's something else to consider, is that we're not solely dependent on federal programs. Check your local municipalities, check your cities, your counties for programs that they have to also support their residents. Another program I want to highlight that is not federally funded, but actually has to do with insurance. We were talking about SNAP benefits for individuals and how that is going to be, kind of in limbo for the next couple of weeks as the government works itself out. Here's a post-discharge meal benefit plan through one of our patients' insurances. So this is not even something where we're consulting an outside facility or any other thing. This is a benefit that if they were admitted for at least 2 days and then discharged, we can get 28 days of meals for them. That's also something to consider for your patients who are actually applying for SNAP, waiting for their final confirmation or waiting for the card to come in the mail, and then also need meals to hold them over until that happens. So not only are we looking at federal programs, but check your insurances, check your local municipalities, things like that, so that you can find all the resources that are available to help your patients, not only through federal funding, but through local programs. I'm going to turn it over to Sarah.
Thank you, Daphne. I know I didn't know about a lot of these resources until I met you and you shared this, so I know this will be helpful to a lot of people. We're going to transition now to discuss some of the challenging clinical situations that we all face. And the first one that we're going to spend a little bit of time talking about is something that I'm sure we've all experienced on some level, which is infection. So as many of us know, infection is something that exists, and unfortunately, it exists throughout the continuum of LVAD. So there is always a risk of infection, both early and late, and it is associated with increased mortality risk. Now, what we would like to try to do is to figure out what are things that are causing greater risks of infection, and are there things that we can do about it? So in this figure here, these two arrows represent the bottom 10% in the green line, and then the red line represents the middle 10 to 90%. And what we would all love to do is to move ourselves to the top 10% there and reduce our infection rate. But what hadn't been known prior to the Aspire project was how exactly do we go about doing this? Now, there have been previous publications by Dr. Kanwar and Dr. Kauger where they discuss the variability that exists in patients that are implanted with HeartMate 3 at different centers and outcomes that result. And we, of course, know that that variability also extends to infection. You can see here highlighted in yellow and with these arrows that there is a difference in infection rate in the 25th percentile centers and 75th percentile centers. And I know we would all love to move ourselves to be in the improving sector, and really love to learn from centers that are doing things in a way that perhaps could reduce infection risk for our patients. So this led us to this Aspire project, which was essentially the acronym for Assessing Site-Specific Patterns of LVAD Patient Management Leading to Exemplary Outcomes with the HeartMate 3 LVAD. And I'd like to just say a big thank you to all of the VAD coordinators on here, because this was truly a study that would not have been possible were it not for LVAD coordinators sharing their center practices. So what we did in this study was define the variability in management. We knew that there's variability in outcome. That was that paper from Dr. Kauger and Dr. Kanwar. But what we wanted to do is figure out, where does this variability lie with regard to infection management, and how can we align that variability with STS outcomes to identify truly what are the best practices that we can do and help our patients. So with that, the methods for the Aspire study involved a very large and extensive survey. And the infection-specific questions represented about 79 discrete items. And there were 30 different centers among the 69 momentum centers that were all included in this Aspire study. We then took the data, essentially the management practices that were shared from the VAD coordinators, and matched that to center outcomes that are reported to the STS. And essentially what we are trying to do is say, okay, we know here's variability in management, and we know here are the actual outcomes. Which variability in management actually improves outcomes, or which ones should we avoid? That was the intention of this study. And so what we did was took the survey, combined it with the STS data, like I mentioned, and then also looked at what are previous publications that have accepted standards of care that we should not neglect for inclusion in making recommendations. And we pulled those three together to offer best practice recommendations through Aspire. If you're curious what centers were included, here is the list of the 30 what we tried to do was be comprehensive, including centers, all across the country of different sizes and patient populations to really represent the LVAD population across the U.S. Now, some things that probably will come as no surprise to you all, being VAD coordinators, is that there was quite a lot of variability in driveline management. Specifically, the dressing change frequency was highly variable. There were some centers early on that were doing once daily or even twice daily dressing changes in the hospital, all the way to weekly dressing changes. So a huge variability in what that frequency would look like, both in the early phase of patient recovery and out to the long term. There are still some centers out there that do daily dressing changes after a patient is 5 years out on LVAD support. There's also a huge amount of variability in the different components of the dressing change kits. Some people use chlorhexidine products, some people have used iodine products, some people have silver-based dressings, some have different biopatch components, and all sorts of other options that were compiled into kits. So we could say, yes, there's a huge variability in the frequency of dressings. There's a huge variability in the actual items within the kit. But what are the things that we actually should take away from this and do as clinicians to offer the best infection mitigation possible for our patients? So if we're talking about big takeaways from the Aspire infection presentation, it would basically be this. Use of chlorhexidine and silver-based dressings overall reduces MCS infection. So if you look at kind of combined results, about a 38% at 2-year infection risk could be attained by combining these two things. So this is certainly something that is doable and attainable. If we look at both early and late, incorporating silver early and incorporating it in late is helpful. So it's not something where you should just say, okay, well, after the patient is 3 years out on LVAD, I'm going to incorporate chlorhexidine and silver. This is something that's helpful through the continuum. And in fact, utilization of chlorhexidine and silver reduces early device infection by 52% and late infection by 36%. So these are very helpful things for us to know when we're thinking about what we should include in our dressing change kits. The other thing that's important to take away is more is not always better. And I think that is an important message from the frequency of dressing changes that came out of this Aspire study. In fact, doing more frequent dressing changes was not helpful. It actually would increase the risk of infection. So the study suggested that it would actually be better in that first 4 weeks to do dressing changes, maybe every 1 to 3 days, not twice per day early on in that hospital course. And when the driveline is well integrated and patients are discharging, 4 weeks post-op, then change dressing frequency to every 3 to 7 days. So doing daily dressing changes a year out on LVAD support is probably not the most helpful thing for your LVAD patients. But of course, the other things to keep in mind are that we should not forget the things that we know to do and to do them well. It's important to adhere to the guidelines regarding preoperative and postoperative antibiotic usage and coverage, also documentation of driveline site visualization and what infection may look like in particular patients, and then also re-education. I can't tell you how many patients I think are doing sterile dressing changes. I see them a year back, and the way they're doing their dressing changes are different than how I imagine that they might be doing that. So not forgetting to re-educate patients on how dressing changes should occur can be a very helpful thing to do. We were hopeful that the Aspire project would not only show kind of where might some of these best practice strategies lie, but really improve outcomes across implanting centers and really energize the LVAD community. And I would say specifically the LVAD coordinator community, because this is a study that was actually done in collaboration with LVAD coordinators to help LVAD coordinators improve the care of patients. So I think this is a very empowering thing for us to take away to say, how can we best improve the outcomes for our patient population? Because we do take care of them. We often are the ones who are involved with addressing changes. And so this is something that we can tangibly take away and do. So if you're interested in reading more about this, here is the link to the publication in the Journal of Heart and Lung Transplant if you want to share this with other people on your team. And also, we did a full hour-long webinar on Aspire studies that will be in the resources tab that you can see after the conclusion of this presentation if you'd like to learn more. So with that, we'll transition to hypertension.
All right. So we know how important managing hypertension is in our post-LVAD patients because increased afterload is increased risk for stroke. And that's exactly what we do not want, right? So a brief synopsis, a Doppler BP is usually closer to what a MAP is. But if a patient has a palpable pulse, a cuff pressure might be better in terms of checking their blood pressure. So in thinking about how the pump is working with the patient and within their blood, with their blood pressure, these are some changes we can expect when somebody is experiencing hypertension. That flow is going to go down on the HeartMate 3 and that PI is going to go up. So these are things that we can look for when we're also evaluating the patient. This is a real world example of a patient who was rationing their Entresto. You can see the changes in the PI here, right? We're at 7.3 in the first picture and then 6.8 in the second picture. You can also note the episodes of PI levels and variability when patient had stopped taking their Entresto and how much higher it was in that first picture. And then in the second picture, you can see the PI readings did kind of go down and stabilize a little bit. There also are more speed drops that are occurring in our patient who is hypertensive versus our patient who is now taking their Entresto and their hypertension is better managed. So in thinking about hypertension, another thing we need to think about is getting our patients on guideline-directed medical therapy, right? Because this does include antihypertensive agents that can help manage that blood pressure a little bit better. And if we're going to get them on drugs, we want to get them on the right drugs. As referenced in this paper by Barry et al., managing an LVAD patient should mimic the management of a non-LVAD patient. So adherence to guideline-directed medical therapy is recommended, right? There are some considerations when we are initiating these therapies. For our ACE-ARB ARNIs, right? Especially for our ARNIs, we want to check the cost, right? But we also want to look at renal function, want to look at potassium, things like that. Our beta blockers are okay to use in our patients that do have RV issues, maybe not in the acute phase of their illness, but it is something that can be explored later on. You may want to start with a low pressor versus a toprol so that you have a short acting drug versus a longer acting drug when you start initiating these things. But this is something that can be implemented, and beta blockers are not an absolute no forever for patients who do have RV issues. Obviously, you're going to use your clinical judgment, but it is something to consider adding because beta blockers also do help with RV remodeling as well. You want to add in your MRA, and that's something to consider as well, because we also know that our MRAs can also impact potassium. And maybe we need to evaluate our reactivity to potassium levels when we are taking care of these patients, right? What is our threshold for wanting to withdraw or remove these medications? Can we actually just reduce the dose instead of taking it off completely? And then with our SGLT2 inhibitors, right? Don't forget, if you're going to start someone on an SGLT2 inhibitor, that you might need to augment their diuretic dosing, okay? They might not need as many diuretics because those SGLT2 inhibitors are going to assist with some of that diuresis. Also want to be following up with your patients if they get UTIs, okay? This is something that can be a side effect of using SGLT2 inhibitors, so it's something to consider, and you don't want to just gloss over it if your patients are reporting UTIs or recurrent yeast infections in women. Even if you've optimized all your GDMT agents, some of these patients may have blood pressures that are still a little bit more resistant to treatment. Hydralazine and nitrates are indicated in African American patients. There's also isosorbide dinitrate and also fixed dose combination. For your patients who you've maxed out kind of on their beta blockers and that heart rate is still not well controlled, you can use ivabrandine. But these are other agents that can be considered once you've optimized the quadruple therapy that is available from your GDMT agents. And we're going to get into right heart failure with Sarah.
Thank you, Daphne. I think right heart failure is something that often worries a lot of clinicians, especially because the LVAD is supporting the left side of the body. And I typically think about right heart failure in terms of kind of congestion, fluid, that sort of a thing. So from an examination perspective, these are patients where they're going to have an elevated JVP, they can have lower extremity edema, they may present with ascites or an enlarged liver. And you can see imaging findings, for example, this chest x-ray here that shows a fair bit of fluid accumulation. Your laboratory findings are often going to be reflective of this, with worsening renal and hepatic function, and your imaging and hemodynamic studies are going to reflect that kind of fluid congestion and accumulation. And so this is something, of course, that we would prefer to, when possible, avoid in our patients. But it's helpful to know what it looks like and what are things that we can do to help patients who may struggle with this. So first of all, let's talk about what it might look like. So if you're seeing a patient, you think they have some of these symptoms that we just discussed, on their LVAD monitor, you may see a flow that is more reduced, and their PI could be lower as well. So when you start to get these puzzle pieces and you're kind of putting them together, these are things that you certainly might see. This in and of itself is not diagnostic for right heart failure, because there's other things, as you'll see in the next section, that also can present with reduced flow and PI, but certainly this should be on your radar or as a part of your differential if you're seeing this. A lot of times if you have additional advanced studies or hemodynamic parameters, you may see things like a high CVP. And an important thing to note is, especially for a patient who may have prolonged or more of a chronic right heart failure picture, you want to avoid the tendency to want to turn up the pump speed, because especially in somebody who has pretty significant right heart failure, for a long period of time, turning it up is actually not going to probably help your patient. It can actually worsen the RV failure by increasing the venous return. So then you're pulling blood out more quickly and sending it all the way to the RV that already is struggling. So in these folks, sometimes you actually need to reduce the pump speed instead of increasing it, which I know sounds a bit counterintuitive. So I do like to point that out. So I think what are the things that can be done? That's, I think, what we all want to know. If you have a patient, you're worried that they have right heart failure, what can you do? I think some of the initial or easy lowest yield, or I guess lowest hanging fruits with high yield, can be volume optimization. So making sure that you're optimizing diuretics in these patients, pulling off fluid to try to help is certainly very helpful in these folks. Now, if you want to take a step up and you're looking for, additional kind of more, advanced or higher medication options, things like pulmonary vasodilators, PDE5 inhibitors like sildenafil have been utilized at some centers for pulmonary hypertension. Some centers also do inotropes, either temporarily or in a more durable, longer-term fashion. Things like milrinone have been used. Of course, then your patient has an additional, infusion and kind of another small bag that they're having to carry around, plus their LVAD if this option is pursued. In the early phase, if you have somebody who's in the hospital, it's always better to plan for a temporary RVAD rather than to crash into one. So if there's a concern that your patient may be at risk for right heart failure, it's better to plan for a temporary RVAD rather than just having your patient need to emergently return to the OR for that support. And certainly temporary RVADs are utilized in the hospital to support the right ventricle. We already discussed a little bit about pump speed reduction, particularly in folks that have kind of chronic, significant RV failure over time, and really avoiding the thought to turn up the pump speed. You want to, if anything, do the opposite. But I think also something that maybe we don't always think about quite as much are what are things that we can do or treat or help that may minimize some of the risks of your patient having right heart failure. So don't forget that a lot of these patients may have underlying arrhythmias. So are their arrhythmia management strategies really well optimized? Do they need improvements from medical therapy or, ICD, CRTD type of perspective? Identifying and treating arrhythmias can help prevent your patient from tipping into right heart failure. And certainly other causes, infection, PE, tamponade, all of these sorts of things can increase the risk for a patient going into right heart failure. So we can implement some of these strategies potentially that we even discussed in the Aspire section about mitigating infection. We can reduce risks for some of the things that can be sequelae of infection or other adverse events. So don't forget to do as much as you can in your power to help treat patients if or when they do present like this. And with that, we'll spend just a little bit of time here talking about outflow graft obstruction before we'll spend a little bit of time answering some of the questions I already see populating into the chat here. So let's spend a little time talking about this, because I think we've all heard about it and maybe have different understandings or appreciations of what this is. So essentially, outflow graft obstruction is this biodebris, or essentially fibrin deposition, that can build up between the actual outflow graft and the bend relief. So there's this gap between the actual graft itself and the bend relief that this biodebris can deposit, and it can accumulate over time. And you can see in the figure in the bottom far left with the yellow and green arrows, you can see how that buildup or accumulation of biodebris can compress the actual graft itself and how that can occlude or limit the flow through the outflow graft. And that, of course, is what can cause problems for the LVAD patient. So here are some other representations of what this could look like. But I think probably as clinicians, what we're interested in seeing is not to say, okay, after the fact, if you take it out, it's obvious that this is what it is. What can we do to identify this early on when this pump is still in the patient, and what are things potentially that we can do? So if you think about it from an LVAD parameter perspective, patients who may be experiencing OGO, whether it's inflow or outflow graft or even just ingestion, will present with a lower flow and a lower PI. Now, of course, if you remember, this is also how right heart failure patients can present. So just this in and of itself is not enough to say, aha, OGO, and now we have to send the patient to the OR. You certainly have to utilize other layers of data to make sure that you have the appropriate diagnosis. But if your PI is increasing, maybe this is something where you want to be thinking more along the lines of hypertension rather versus a lower flow, maybe is more, OGO, right heart failure, or other options. So again, this is how it would look. And why would there be a lower PI or lower flow? Well, essentially your maximum and your minimum flows are going to change. So when you have lower maximum flows, then the difference between the peak and the trough is narrower, which then causes a smaller or lower PI. So essentially lower flow and lower PI in these patients. So the question is, okay, you think maybe your patient might have this. How do you then go through some sort of an algorithm to really get to a more formal diagnosis? So there were two very helpful publications by Dr. Mehra and Dr. Goldstein that kind of outline what is a good strategy to take to figure out what might be going on in these patients. So we'll go through each of these. The first is this one by Dr. Mehra here. And you can see at the top, if there is concern for a patient, let's say you think might have OGO. So maybe they have lower PIs, lower flows, and in some cases, this can even be low flow alarms. So as you can see in this figure here, if the patient is having low flow alarms, persistent low flow alarms, this should certainly be on your radar to consider. And so these are folks that you're going to want to evaluate a little bit further and rule out things like hypovolemia or low volume, bleeding, tamponade, right heart failure, like we discussed. You want to make sure they're not hypertensive, that they're not dealing with arrhythmias. And if you've ruled out, a lot of the things that it isn't, then you have to wonder, is OGO the thing that perhaps it could be? And truly the diagnostic modality that you're going to utilize to make this determination is a CT angiogram. So this is kind of that figure you can see in the lower right corner, where it will actually show you whether or not obstruction is present. The contrast will allow you to see whether there's nice kind of smooth flow through the outflow graft or whether there may be some obstructions. And if there is, then the question is what to do. So sometimes these folks will benefit from surgical repair where they will go to the operating room to have the biodebris removed. Sometimes this is treated in the cath lab with stenting, and a lot of this is very much patient specific and depends on the extent, amount, and location of the fibrin deposition. Now, not all patients are going to have this. In fact, it's the minority of your patient population that are going to experience this. So you can see on the far left of this algorithm here, for your standard patients who aren't dealing with this, you can continue to monitor them. And the things that would maybe clue you in early to have something like this be on your radar could be if, let's say, the flows normally are 5 or 6, and now your flows have kind of trended down over a year, and now they're 3 or lower than they were before. That's something then to keep on your radar. Or if your aortic valve previously was closed on echo and now it's opening every cycle, maybe your mitral regurgitation is worsening or your LDH has been rising. These are all things that should clue you in to think about whether this is something that could be going on in your patient. Similarly, Dr. Goldstein also created a very helpful algorithm that helps rule out concerns for OGO. The thing that Dr. Goldstein's algorithm also includes is to certainly rule out the other possibilities, but then he suggests to do an echo plus or minus a ramp study to help determine whether you have normal or abnormal findings. And the abnormal findings on your echo or your ramp echo are then what would trigger that CT angiography study to help determine whether your patient has OGO. And then from there, these same interventions would apply, whether it's surgical interventions, stenting, or other options. Now, a very important thing is that this is something that will end up being a historical concept because Abbott has a new outflow bend relief that's standard of care now. And on this next slide here, you can see how there's these perforations or essentially slits that are intended to mitigate the risk for OGO in the future. So this went live in Q2 of 2025. So this should not be a problem on patients moving forward, but historically, it's something that you have to be aware of. Or also if you have a surgeon who, let's say, wraps a bend relief in Vortex or something like that, those sorts of things are important then to consider in populations that you need to think about OGO. So this is just a cautionary tale. I think that it's not common. It's pretty rare, but it's good to know about it if or when it were to occur. So with that, I think we'll open it up to questions. And I see we still have quite a lot of infections related questions here. So we could do some of those, but maybe I'll just ask Daphne, what just for the SNAP benefits here, what are some things that we can think about for folks, where maybe they're worried, they come to you and they say, hey, Daphne, I'm worried about all of these things that could be happening. Where should I look for resources, to help get me until next month or the next 2 months?
Yeah, so the quickest would be your local food banks, which are typically associated with churches and other charities because they will have already preset schedules. They've already been operating. They're not screening individuals for any resources. So it's just a matter of finding a local food bank that you can direct them towards. After that, once I've directed them towards a food bank, which can hold them over for a week, 2 weeks, things like that, I will look at other options like our other charity meal services that are kind of like your Meals on Wheels or things offered through churches where it does require more paperwork. But the food bank would be my first because that is kind of just, they can show up as is, get what they need to hold them over. And then I would pursue those other avenues. And I see there are questions here for you. One of the questions that came up is, do you still use silver on someone who has a driveline infection with drainage, or do you just have them change daily, or do you just use gauze?
Yes, so I think this is a great question. And I will say that the study is essentially targeting patients who are stable, where the site is well integrated, and not people who are actively dealing with infections. For people that have active infections, often the frequency of dressing changes necessarily has to be more often. So these are folks where they maybe are going to need to do daily dressing changes in order to be able to keep up with the amount of drainage that they are experiencing. So the recommendations that were shared here are for your patients that aren't dealing with active infections, for patients that are stable, and is an attempt to avoid or reduce the risk of getting to infection in the first place. But I think it says here also, do we change dressing? At my center, I will say yes, we do. We change the frequency. Often we have to do daily dressing changes because of the amount of drainage that somebody may be having in the context of an active infection. We're fortunate that we have pretty good resources at my facility where we are using silver in those kits. I know sometimes finances can be a challenge, and I think that sometimes it can be a struggle to get things covered simply because of the paucity of data that previously existed. So I think that utilizing publications like this to submit for coverage can really help to hopefully improve options for patients where maybe perhaps in the past silver or something like that may not have been feasible. And I wonder, Daphne, I know I
just wanted to piggyback off of your response to that question. We also want to prevent polymicrobial infections. So I think at our center, we will still continue to use silver, even when patients are draining, because there is still the risk of other infections occurring, right? Because if you have MRSA, you definitely don't want to add Pseudomonas on top of that or something like that. So I think thinking of preventing polymicrobial infections is another way to kind of consider how you want to manage these patients as well, because you may need to change the frequency of dressing just because you don't want maceration of the tissue, but you also still kind of want to prevent other bacteria from infiltrating that area.
Mm-hmm. And if you don't mind, Daphne, I may just kind of tackle a couple of these infection-related questions because it looks like there's a fair bit that deal with these specific findings from Aspire. There was a question about whether or not it was CHG or chlorhexidine for cleansing plus silver dressings. And essentially it was basically the use of chlorhexidine for cleaning and then the silver dressings. That was what was found to have the best risk of reducing infections. As far as recommendations for frequency of showering, there was not enough data for us to make formal recommendations about showering frequency, whether you should shower, not shower, or how often. I will say that if you have a patient who showers, you should certainly advise your patient to change their dressing after showering. So if there's somebody who's showering, twice per week, that I wouldn't do a weekly dressing. I would do a twice per week dressing on that particular patient. I will also say that there are some centers that are adamant against their patients showering because if you struggle with Pseudomonas, for example, that can be a waterborne organism. And so minimizing exposure to water may reduce these risks. Again, it wasn't powered to make these conclusions, but these are things that people have considered with regard to showering. And then as far as training patients on doing dressings, it kind of depends on the patient. I mean, I'd like you to maybe chime in on that, Daphne, because I know that there's a bit of variability, probably depending on the age and kind of flexibility and capabilities of your patient. A lot of ours find looking in the mirror to be a helpful way of being able to practice. And sometimes what we've had them do is practice on a mannequin in the hospital first, so they feel comfortable doing it in a controlled environment first before they practice on themselves. But perhaps you have other thoughts?
I find that it's really body habitus dependent. Certain patients, if they are, laying in bed and they can visualize their drive line, they do perfectly fine changing it there. But I actually prefer having them stand up, opening that bedside table mirror, because it's just more room. There's less crunching. They're not limited by like sternal pain, less likely to contaminate their gloves because we use sterile technique. So I find that body habitus is really going to be the driver for us, how we are going to teach patients how to change their dressing. And I really don't think there's like a one size fits all. I think based on the individual and how they're doing is going to really be the determining factor on what positioning and what technique is going to be best for them. And in regards to showering, similar to what you said, if you're showering multiple times, we want that dressing change after every single shower. And, plug for your paper regarding cleaning the shower head. That's a big thing as well, because that can be an area where bacteria is being harbored as well and can be the cause of driveline infections, especially you mentioning Pseudomonas being in the water supply for some individuals. In New York, we have Serratia in our water supply. So something to consider when you have patients that are showering.
Sure. And it looks like, Daphne, there's a question here that talks about essentially how do you, what are the challenges that you've experienced to coordinate the different services to refer to advanced heart failure therapy, or what do you recommend to ensure that care delivery happens at your particular center?
So our attendings do an amazing job of when someone is referred, that appointment is happening immediately, because that is a big thing as well, especially if you have someone whose heart failure is, a little bit more advanced. You don't want them back in the hospital before they received care from you, because then it's another opportunity for them to kind of be lost and someone to kind of lose confidence. And hey, I needed this patient seen right away and it didn't happen. So I do find that, our heart failure attendings do an amazing job of getting these patients who are referred into our clinic as soon as possible and having that open communication. Our team is very accessible. And that has made a huge difference. Can it be inundating with a lot of people and a lot of volume? It can, but I think if you have things that are in place to manage that and your whole team, right? Because it's not just the attending, but the coordinators who have to complete the eval, the front desk staff who has to schedule these appointments, the room turnover. It really is a whole entire team thing and not just a referral kind of gets thrown at you. So I think getting your whole team on board and recognizing, hey, this came in, this needs to be scheduled at this time frame, and having clinic slots that are allotted to these specific patients can help manage the flow a bit better instead of it just being someone gets a referral and they kind of just get thrown into the mix.
Mm-hmm. And it looks like I think we maybe have two more questions. So I'll maybe ask you, Daphne. I know it says here that some centers there's different strategy. Some people they will say, okay, be clean, kind of going in a circle, and others kind of do hashes or scrubs. I will tell you that the Aspire study did not ask, do you circle or scrub, or what way do you do it? I'm not aware of data that shows that one is superior over the other. I think at my center, we primarily teach circles. I'm not sure what you teach at your center. I'm not advocating for one over the other, but I don't know if you have a different approach that your center takes.
No, we actually just use circle for everyone. I think it just standardizes our education as well, because for our patients who do have chlorhexidine intolerance, who do have to use iodine, you wouldn't want to recontaminate with the iodine doing hashtag type of cleaning. So we just universally teach everyone to kind of start in the middle and work your way out. And we don't differentiate any other type of cleansing method.
Yeah. And maybe I'll just kind of answer these last two here, and then we can wrap if you're okay with that, Daphne. There was one about the strength of the chlorhexidine, and I would say follow the packaging recommendations. You do not want to use overly concentrated chlorhexidine because that can be caustic to the skin, but you don't want to dilute something to the point where you lose efficacy. So follow your package inserts and the guidelines and instructions on the kit. And then also there was a question about, does our center put patients at the top of the list if they are further out on support? So I think that maybe what this individual is referencing is that in the future, there's going to be some time for LVAD support that will help patients maybe as they're listed for UNOS. So this will be coming in the future. Essentially, time on LVAD will count towards time allocated for transplant. So this is not quite yet live, but this will be in the future. So it may be an option for folks that have had LVAD support for quite some time, that they may be a little higher on the list than somebody who would otherwise be an equivalent patient, but has only been supported for, let's say, 6 months. I don't know if you have any concluding remarks otherwise, but I think we've gotten through most of the questions here.
Yeah, no, I think we're good. Thank you guys so much. This was so much fun.
Mm-hmm. Yes, thank you all for attending. This is great.
And with that, then, on behalf of Abbott, we owe a big thanks to you, Sarah, and to you, Daphne, as well, for sharing your experience and your insights here today, taking time for those questions as well. So we want to thank you. And we want to take a chance to thank all of our guests and attendees for joining us here today as well.